I'd like to introduce to you, I'll introduce them both, and then Katherine will go first. Katherine Berg, she's Associate Professor from the Department of Physical Therapy, University of Toronto. And I have to say, Katherine paved the way for me at Brown because she had been a postdoctoral fellow before me and then had stayed on as a faculty member and had left just the year before I arrived. So we did not overlap. And our other visiting fellow is Kristin Archer, Associate Professor and Vice Chair of Research and an Orthopedic Surgery Associate Professor in Physical Medicine, Rehabilitation, Vanderbilt University Medical Center, and she's our second CoHSTAR visiting scientist. I think I blurred all of your affiliations together, but I'm sure they'll be readable on your slides.
Okay, well, it's my pleasure to be here today. It was really a pleasure to be part of this CoHSTAR as a visiting scientist. It was during this time I was on leave from the University of Toronto, having completed 10 and a half years as chair, so I needed some fun time, and going back to Brown was fun time. And it's changed so much. Where I was just talking to Linda is when I was there in the 93 to 2000, there was really not much emphasis on post-acute care or rehab. So it's actually a pleasure to see all the people working on a program grant now in post-acute care. So lots of colleagues actually now. So what did I want to accomplish on this during this time? Well, I'm a physical therapist. I'm still a bit of an outsider because I do come from Canada, different healthcare system. It does take me a long time to learn all your initials and, how you consider all the MPAC and all the, Medicare, PPS, SNF, everything. But I got a dose of it this fall. But it's been a long time, truthfully, since I worked daily clinical practice. I work mostly in neurosurgery, medicine, and helped set up the first geriatric rehab unit in Montreal General. And that was like 1982, so you can tell how old I am. And that was a great time. I loved it. And I must admit that probably the patients we treated there stayed longer than most of the patients who go to acute care and SNF now, and probably home care. Because I think Nancy Mayo had once done a study where the average length of stay for stroke patients, for example, was 35 days in the mid-'80s. So it was a different era. But as someone really interested in geriatrics, and I always have a positive attitude to how people will improve, I loved getting patients up early and moving, and spent also almost equal time in the gym and on the unit to make sure that the nurses, nursing staff, everybody knew what progress the patient had made or was making, and tried to, set up the environment, et cetera, for them to practice. So I'm a strong believer in early functional improvement. And I wanted to see, using this amazing data that Brown has in the MDS, what's early functional improvement a predictor of successful discharge from SNF? So, and we also looked at this for different patient groups, including stroke, hip fracture, COPD, and CHF. It really was made possible by the MDS, which is required to be completed at 5 days, 14 days, 30 days, and 90 days, or at discharge, whichever one of those comes first. In the MDS, the ADL items have, as Vince had mentioned, high reliability. Each one of these 7 items is scored 0 to 4, so the ADL long form is a 0 to 28 item scale. All right. Our operational definition for this paper was successful discharge, being discharged to the community in 30 days, and also followed 30 days post-discharge from SNF to make sure there was no rehospitalization and no readmission to SNF or any nursing home, and did not die 7 to 30 days post-discharge. These are the data sources that we used, and I won't go through this too much because Vince had mentioned these data. The cohort selection, we had patients from 2012 to 2014, but they had to have, if they were discharged from SNF, had to be discharged before December 1st, 2014, in order to have that 1 month's follow-up post-discharge. We also pre-selected so that we had a little bit more of a rehab type, well, not quite rehab type, yes, well, more closely a rehab type population by saying no previous SNF claim or MDS 3.0 assessment in the previous year. And they were in Part A SNF. We also had some exclusions, including people who had died within the first 7 days of first discharge, because we thought that those were probably different people. Now, this is a graph that actually doesn't look that different from some of the other ADL graphs that we've seen from people in acute care and home care, I think. So the average, the median ADL score is 19, and very few people are relatively functionally independent. So we have quite a bit of functional dependence in SNF, which is probably not surprising. But it does mean that if you're going to be looking at any kind of modeling to look at successful change, one would have to look at adjusting for baseline ADL. So we chose to divide this by quintiles. So 0 to 12, 13 to 16, 17, 18, 19, 20. You can read that, hopefully, yes. So this is the model, one of the first models we ran. And it does show in yellow that the odds of successful discharge are improved if the patient does has at least 2 points of improvement. So again, just to, I'm sure everybody knows this, but so a confidence interval that does not include 1 is statistically significant, so 95% confidence interval. And, you know, not unexpectedly, bowel incontinence, CPS scores, lower CPS, so poorer cognitive function, are associated with poorer outcome. Pressure ulcers associated with poorer outcome. Communication not in this sample, vision, and these various diagnoses, stroke, hip fracture, and COPD. And progressively, as you increase your baseline ADL scores, it's less likely that you have a successful discharge. Not perhaps too unexpected. So this, again, just repeats what we saw on that slide. Here is the model with quintiles of functions. So the odds, oops, wait a minute. Yes. So the odds actually are still important that you have at least 2 points of function that predicts a successful discharge. But for those people with more impairment, sort of the middle areas of impairment, it's even more important. Okay. And that remains true for each of, we repeated this for the various 4 diagnoses. The red line here is hip fracture. The other 3 follow pretty well much as how the general population was in SNF. Hip fracture is even more important that one works toward functional improvement early in that period because that has better outcomes. So what can I say? So early functional change is associated with higher odds of successful discharge. And I really want us to be able to focus on getting early functional change. It's not totally dependent on physical therapists, but how we work together and how the whole SNF and the organization receives information from acute care, how well the interprofessional team works together, how well gains in physical therapy are reinforced upon the unit, should all work together. And I think we do have a role to play in ensuring that patients and that the organization focuses on this change. And this information is readily available. As ADLs are included in the MDS, and it has the potential of being a quality indicator. And I must say that I have seen physical therapists over time distance themselves to a certain extent from basic ADL measures or IADL measures. And I think it's important that we do pay attention to them because others are actually looking at nursing homes and evaluating to see what the effect is of greater intensity of physical therapy on ADL. So when they don't see a change, I think it's important for us to be paying attention to this. And so what our next steps are, because we haven't completed this completely, is to explore facility level factors. So when we put in a random effects facility model, the odds ratios actually went up. So it became even more important that the patients had early functional improvement from days 5 to 14. And so we want to explore what are those facility factors. Are they the number of physical therapists, the physical therapy assistants? Is it different other staff requirements? What are the facility characteristics? Or in fact, is it volume? So previous work has looked at volume of hip fracture patients being predictive of better outcomes for patients with hip fracture. So we will be further exploring that because, again, Brown has the data from of facility characteristics. And of course, it's valuable also to be considering what are the different practices and roles of how PTs work together with nursing staff and how the staff is organized as to how that might impact greater functional improvement. And I do hope, and I think through today, people have been talking about quality indicators, and I hope that we do manage, through all the work that everyone's doing, including this, is to get physical therapists to become aware and feel that they have a role to play in the quality indicators of the organization for which they work. And I've also been working with collaborators at the Hebrew Rehab and my Inter-I colleagues for developing quality indicators at an inpatient post-acute level. So there's those at aggregating the information of the early improvement, but other quality indicators, looking at inpatient post-acute care. And so this is my list of potential my collaborators and co-authors. So Pedro Gonzalo has been instrumental in helping me, and Joe Servaggio, and various discussions and assistance from others at Brown. So it has been fun, and it will continue. So thank you very much.
Thank you. So it's been an honor to work with CoHSTAR this past year and see all the progress. And I have to say, as a PT with a PhD in health services research, I've been waiting for CoHSTAR for about 5 years now. So thank you to Dr. Resnick and also to the Foundation for Physical Therapy for having the foresight to think about this funding mechanism and to be supportive of it in HSR. So I had my visiting scientist position at the University of Pittsburgh, and I had two objectives with my visiting scientist position. The first was I wanted to learn about pragmatic trials by working with Dr. Tony DeLito. So I want to thank him for spending considerable time with me, teaching me about pragmatic trials, and also letting me observe the target meetings. And there's nothing like being immersed in the trial as it's being developed and kind of being implemented and rolled out. So it was a really tremendous experience this past year. My second objective was to learn about cost effectiveness analysis. Most of my work is randomized trials, and I felt like that was my missing piece, that I really wanted to be able to, after looking at the efficacy, then really focus on the cost piece. So I worked with Dr. Ken Smith. He's a professor of medicine at Pittsburgh, and he has a course on the economic evaluation of healthcare programs. So he created with me a long-distance learning module, so I was able to complete the coursework and the projects from a distance. And then after we were done with the coursework, after 6 months, we then did a cost-effectiveness analysis using my own data with my randomized trial. And the deliverable, working with Dr. Smith, was a manuscript that we were in the process of submitting to JBJS. And today, I'm just going to talk a little bit about the manuscript, the methods, and the results. So the data we used was from a recently completed randomized trial that was funded by NIH. And we compared a cognitive behavioral-based physical therapy program, or CBPT, to an education program in patients following lumbar spine surgery. So the programs were delivered by physical therapists over the telephone, and they were delivered between 6 weeks and 3 months after surgery, and the main results are published in this paper in the Journal of Pain that came out in January of 2016. So the consort diagram, very briefly for the trial, we randomized 86 patients after surgery, 43 into each group. And we assessed patients before surgery, at 6 weeks after surgery, 3 months after surgery, which was post-intervention phase, and then 6 months after surgery. And we had a 93% follow-up rate with our primary outcomes. And these primary outcomes were pain and disability. And what we found at 6 months after surgery for these, just the primary, we had several secondary, but I just want to briefly give the results, was that the CBPT program was significantly improved compared to the education group with regard to the pain and disability. We also found significant improvement with our secondary outcomes of general physical health and general performance. So with this specific manuscript and this analysis, biopsychosocial approaches are becoming more common. We heard a little bit from Tony DeLito about the target trial in psychologically informed physical therapy. And this intervention that we developed, CBPT, falls into that or falls under that umbrella of psychologically informed PT. So for this analysis, we actually followed patients longer, so we also got a time point at 1 year follow-up, and we used Markov decision analysis to look at the cost effectiveness of our program in relation to the education program. So with Markov decision analysis, the first thing that we need to do is to define health state membership. And with our population with spine surgery, we define this as 3 different health states. So patients could either be better after spine surgery, not better, or they were better and then they became worse. And we define these health states by using the Oswestry Disability Index. So the ODI is the common outcome measure used in spine surgery. It's the most responsive to change over time. And more importantly, it has an established MCID of 12.8 points. So that's what we use at 12.8 points to define the initial placement into the health states. So at 6 weeks after surgery, they were categorized as either better or not better, based upon an improvement or not having an improvement of this 12.8 points. And then patients could transition over time, the year after surgery, based on this change in ODI of 12.8 points. So they started better or not better, they could transition from better to better than get worse, or if they were in the not better category, they can transition to better or then better than get worse. And so the next 2 slides are just showing the distribution of our patients across these health states. So we have our assessment time points down here, 6 weeks, 3 months, 6 months to 1 year. So if we look for the CBPT program at the green bars, that's the patients that are transitioning over time into the better health state. So we see kind of an improvement with more patients moving into that health state, and then patients moving out of the not better health state. And then what's here for us was the most important is this 8%. So 8% of patients at a year moved from this better health state to then better and get worse. And if we compare that to the education group, we see from 6 weeks to 3 months that our patients are moving into this better health state, but then they're moving out as they progress from the 3 months to the 1 year. So if you look at that 1 year time point, we have 25% in the education group have moved from better than better to get worse, whereas we have 8% in the CBPT group. And what's really interesting for us is that if you look at this trajectory for the education group, it's very similar to what we're finding in prospective cohort studies. That we see this really nice initial improvement, but then we have this group that is just kind of moving back, it's going the wrong direction over time. And that's why we developed the CBPT program, is trying to target that patient population. So for Markov modeling, after defining these health states, we need to capture utilities. And we did that with the EQ5D. And we assessed the patients at 3 months and 1 year with the EQ5D. And the EQ5D, if you're not familiar, goes from 0 to 1, and 1 is perfect health or better health. And utilities can be converted to qualities or quality adjusted life years, which is important for the Markov modeling. So 2 important things about this slide. If you look at both groups And you look at the better group, for both groups, they have better health, which is what we expected. And then for better than get worse, they actually have the lowest scores or the worst health compared to the other health states. And then if you compare our intervention group to the education group, you see that the education group has higher scores across all the health states, which suggests that the intervention is potentially more effective compared to the education group. And the final piece of the Markov model is a direct medical costs. So we gathered this data through hospital billing records, and we also gave patients questionnaires at 3 months and a year. And what we wanted to do, and what we do in our registry at Vanderbilt, is to capture any events that occur outside the Vanderbilt system. And then we derive the cost based on the CPT codes, based on Medicare allowable amounts. And so our model was a state transition model, and we used a $20,000 per quality gained criterion, which is an established criterion to determine if it's favorable to adopt the intervention. And we used data from 2 sources. We had the randomized trial, the Oswestry Disability Index, over these 4 time points. And then we have a prospective registry at Vanderbilt, and through that registry, we gather utilities as well as medical costs. So we're able to pool those 2 data sources. And then with Markov modeling, I showed you the base case values in one of the slides and kind of the range of values. So that's what you use for the Markov modeling. And some people use data from the literature, but we were able to use the data, the base case values and the ranges specifically from our data in the trial. So with our model, you perform one-way sensitivity analysis and you vary all the parameters or values over the ranges to see if your model is stable. And so after all this work, and most of the work is actually getting, the medical costs and thinking about your health states, and then you get this one final model. And what we found is that the intervention is dominant, it's cost effective, and that the CBPT cost $102 less per person and gained 0.09 more QALYs. And what I didn't mention with the direct medical costs is that we also included in our model the costs for the programs. So the time of the therapist to deliver the education and the CBPT program and any training costs involved, and that was also varied in the model. So as we did the sensitivity analysis, we found across most of the ranges and values that the model was stable and it remained cost effective. However, with a few of the extreme ranges, when we varied cost for those in the better category and varied the probabilities for remaining better at the extreme ranges, we found that that dominant result, we lost that dominant result. However, it was below the $20,000 per quality gained criterion. So this suggests that the intervention is economically reasonable at these extreme values. So just thinking about the clinical implications for the trial kind of in general, and also this cost effectiveness analysis. It supports that physical therapists can deliver these behavior change strategies, and we heard that from Dr. DeLito as well, thinking about the target trial and psychologically informed therapy, and also that the feasibility and acceptability of phone rehabilitation, that these behavior change strategies can be delivered over the phone by physical therapists. And that it's a way for us to start thinking about low-cost evidence-based programs and thinking in an innovative manner about how we deliver our services. And it has implication across various populations as we're moving into bundled care payment systems, as well as thinking about more kind of value-based programs. And then finally, which I didn't introduce in the beginning, is that this group that we targeted was high risk. So similar to how Dr. DeLito is using the StartBack screening tool, we use a fear of movement screening tool. So this is a very high-risk group. We've screened them in, and we're providing a very targeted treatment. And what we're seeing with our results is that it's economically reasonable and perhaps cost-saving. So that's all I have. Thank you.
So we have a minute or 5 minutes for questions to either of the visiting scientists. So if you have a question, please raise your hand. Kelly. And you can sit at the mics.
Thank you both. Excellent talks. Katherine, I had a question for you. So you used total score, ADL score for predictor, and I was just curious if you also maybe went a little granular, saw if any of those specific items might be more important than others in predicting, or if that's possible.
I did look at those, but I didn't put them in the model. But I did look at where the changes were. I mean, I don't have the numbers off the top of my head, but I am envisioning it is more in the mid-loss ADLs, so transfer and locomotion. I will verify that and let you know.
Yeah, I think it's important, especially if, early change is really important for us to know what to target would be really important. Thanks.
Okay.
In the back, there's a question.
Hi, Christine McDonough, Boston University. This is for Kristin Archer. Thank you. That was a wonderful talk. You're writing your paper, I think, and one of the questions I guess I'd like to probe a little bit about in your paper, are you comparing these incremental cost effectiveness ratios to other interventions in the field? Because I love that you were really conservative with your $20,000 per quality value, but many interventions don't go near that and are in the up to $50,000 to $150,000 per quality. So it might be a nice thing for you to address. Could you talk about it a little bit?
Sure, I think it is. For this specific paper, we were just focusing on kind of our trial data and the comparisons, just using our data and not kind of thinking about going broader to compare it to what has been published in the literature. However, I think it's excellent to consider that, and probably we might look at that in the future. But for this specifically, we were just wanting to focus on our own data, not go into kind of the published data. But your question though about from the criterion from 20,000, I'm not sure, I might not understand the question completely, but we use that just as a kind of conservative criterion, and I agree that you're seeing kind of people can use that in different ways and pick different criterions across from thinking about different types of programs. As we look forward and we think about the cost effectiveness ratio and looking into spine surgery in general and different programs that are out there, I think it will be really important to kind of compare it to.
Like just for example, some of the cost effectiveness ratios that came out of the spine patient outcomes research trial are over $100,000 per qual.
Right.
So I think it's critical
Yeah.
to think about that. Like you're coming up with dominated interventions is a really relatively large finding.
Mm-hmm. Yeah. Yeah.
So it's nice, it would be nice to highlight that.
Yeah. I see. Yep.
We have time for another question.
Yeah, that's good.
Tony?
Testing your running skills. Kristin, do you think a year's enough?
So follow up, you mean?
Well, really,
So,
I mean, how many of these
Yeah.
people are going to go into? I mean, I'm wondering about
right.
this 25%. Go ahead.
Well, it's interesting because we were just talking with our spine registry about how far we should be following patients. Actually, the spine surgeons are starting to think that 1 year is enough, that this outcomes are pretty similar to what we're seeing at 2 years. And we're actually about to be doing a study on that. Is that what you mean? Like how long should we follow spine surgery patients up to see the progression of those becoming worse over time?
But what about, I'm thinking those patients that end up 25%, those 25%
right.
that are
Yeah.
worse, and then what kind of costs are they accruing
Yes.
after
Yeah.
2 years, 3 years? Do they become failed
Yes,
spine
right,
patients?
Right. No, it's a great question, and we're not capturing the revision rate. So because we don't, we also had a health statement that was revision, and we had one in each group. But you're right, we have to follow patients out 5 years, 10 years to actually see the costs with regards to kind of the failed back syndrome and having surgery again, and we don't capture that within the year.
Okay, I think that we thank you very much for your presentations, and it's been delightful having you associated with CoHSTAR this year.